primary periodontic lesion. The lesions are caused by periodontal disease. Periodontitis gradually progress unchecked along the root surface until the apical region is reached. As we said, it is caused by periodontal pathogen. Frequently, we see accumulation of plaque and calculus are seen throughout the dentition. Pulp vitality tests are clinically normal. Periodontal pocket will be wider and are generalized. Primary periodontic lesion with secondary endodontic involvement. As periodontal lesion progress toward the apex, lateral or accessory canal may be exposed to the oral environment, which led to necrosis of the pulp. The pulp may become necrotic as a result of infection entering through apical foramen. Pulp necrosis can result from periodontal procedure where the blood supply through an accessory canal or the apex is severe by accurate. True combined lesion. These lesions occur where an endodontically induced periapical lesion exists on tooth that is also periodontally involved. The radiographic infrabony defect is created when these two entities meet and merge somewhere along the root surface. The degree of attachment loss in this type of lesion is large, and the prognosis is thus guarded particularly for a single root teeth. Potential complication of endodontic therapy. With any therapeutic modality, complication may arise during endodontic treatment. Some are of iatrogenic nature, such as perforation of the floor of the pulp chamber, or rotogenic access, canal instrumentation, or preparation for a post. So, this accident may result in the periodontal defect, and treatment should be instituted as soon as perforation of the lesion will be occurred. Prognosis. It is depend on patient oral hygiene, the amount of attachment loss, endodontic status, effectiveness of periodontal treatment accomplished. If a primary endo, good to excellent prognosis. Primary perio, it is depend on the periodontal therapy, while combined lesion, it is a poor prognosis. Treatment. Treatment will be involved in a primary endodontic root canal treatment only, while in the primary periodontal therapy, a primary endodontic, secondary periodontic, root canal treatment, and periodontal therapy. A primary periodontic and secondary endodontic root canal treatment if needed after a 3-month interval, scaling and root planning, and then regenerative procedure. A true combined lesion, root canal treatment, and also periodontal therapy. Periodontics orthodontic interaction. The main objective of periodontal therapy is to restore and maintain the health and integrity of attachment apparatus of teeth. In adult patients, the loss of teeth or periodontal support can result in pathological teeth migration involving either a single tooth or a group of teeth. This may be result in the development of diastema or general spacing, rotation, or tipping of bicuspid and molar with the collapse of posterior occlusion and decreased vertical dimension. So, orthodontic treatment can often correct this problem, or at least prevent them from progression. Orthodontic treatment may be improve periodontal health in these circumstances, but it is also holds some potential for harm to the periodontal tissue. Thus, orthodontic treatment can refer to as two-edged sword, which may be sometimes meaningful in increasing the periodontal health status, and sometimes harmful procedure, which can followed by several types of the periodontal complication. So, The interrelation between periodontic and orthodontic often resemble symbiosis. Gingival problem. The development of gingival inflammation during orthodontic mechanotherapy is associated with a specific bacterial type. Hither et study microbial flora in plaque of patients undergo orthodontic treatment and found a definite increase in plaque score when compared with a control patient. The bacterial plaque was composed of spirochete and motile rods. Other authors reported increased level of bacteroid and streptococcus species after orthodontic band. Optimum orthodontic force. The optimum orthodontic force, which are used to move the teeth, in which are produced desirable tooth movement rapidly, with a minimum tissue damage and clinical discomfort. There will be different type of orthodontic force. It is either tipping movement, bodily movement, extrusion, rotation, and intrusion, in which tipping movement force 35 إلى 60, bodily movement force more than 120, and intrusion, it is less force that will be used, 10 to 20, because will be produce alveolar bone resorption. Idle force should not disturb the vitality of the periodontal ligament and should be efficient bone remodeling. Direct bone resorption should occur and teeth should be moved relatively smoothly in an uninterrupted manner. Minor surgery associated with orthodontic therapy: fibertomy, phrenectomy and phrenotomy, gingivectomy. Fibertomy. It is an orthodontic surgical procedure designed to sever the gingival fiber around tooth. It is usually reduce the tendency to relapse of tooth rotation, corrected by dental braces or other treatment. It is used to reduce the occurrence of rotational relapse. Relapse may occur anywhere, but it is often associated with teeth that have undergone rotation as a part of orthodontic therapy. Two types of fiber that will be influence the stability: principal fiber of periodontal ligament and the supraalveolar fiber. A fibertomy involves the detachment of fiber that attach the tooth to the bone via the gingiva. It is performed near the completion of orthodontic and is shown to be effective in prevent the relapse of teeth. To perform this surgical procedure, there will be a surgical cutting of disrupted transseptal fiber by making a gingival clavicular incision under local anesthesia after orthodontic alignment. The procedure painless as long as the patient take an analgesic after numbing has worn off. Phrenotomy and phrenectomy. Abnormal frenum attachment result when a V-shaped bony cleft is formed between the two central incisors, and a thick frenum resists orthodontic force and is responsible for the relapse of space closure. Phrenectomy is more commonly performed procedure. The undesirable loss of interdental papillae is common complication in contour with this procedure. Phrenotomy, despite being it is a superficial procedure, it is aesthetically preferable. Gingivectomy. Most of the time, the gingival enlargement in orthodontic patient is heterogenic, mainly because the long time of treatment. The treatment protocol for such gingival overgrowth is careful training in oral hygiene along with a surgical technique. It is either done by surgically or by laser. The proper use of soft tissue laser in orthodontic patient can improve the quality of result, decrease treatment time, and reduce appointment. Laser treatment can be completed quickly, painless, and infection-free with a minimal side effect of the patient.